As you guys know, this panel, this topic is maternal-fetal health, but we're focusing in on the maternal piece, which is important. And I appreciate Dr. Clerk's commentary to show the difference between the maternal mortality rates and that of the fetal and perinatal loss rates, which are important. So welcome to our panel discussion, which we will start to think about something that Joan Reed has really instilled in us when we were fellows, which is to start thinking about disparities solutions. How are we going to address these inequities through policy? How do we then lead to measurable, demonstrable solutions to tackle these issues that are so great and really lead to what we call right now a human health crisis? So with that said, I want to introduce our panel and that we've brought up to look at some systemic interventions of how we can address maternal fetal issues, but specifically looking at this maternal mortality rate and the issues related to maternal mortality. So welcoming to our discussion, we have Dr. Fifi Diop, who is not only our state of Massachusetts director of the Office of Data Translation for DPH, but she's also an MCH powerhouse. Dr. Diop has been a practicing OBGYN, serves as a state maternal and child health director and epidemiologist, also is the director of the Massachusetts Pregnancy and to Early Life Longitudinal Project, which is a linked database system, very important to understand and learn because not all states have that system. In addition to that, Dr. Diop has her MPH and is a champion for public health. She has been our person who has conceived of our state perinatal quality collaborative, and what makes our quality collaborative different from other state perinatal quality collaboratives is we take a very strong life course approach by connecting the work that we're doing on the neonatal side to the maternal piece to areas of intervention in public health, such as early intervention and Head Start. And we have that because of the great foresight of Dr. Diop and all that she brings to us. I want to also let you know that not only is she a colleague and a friend, she's also a phenomenal dancer, so I enjoy attending conferences and meetings with Dr. Diop. She'll talk to you today a little bit about using public health data to inform clinical practice, and I'd like to bring up Dr. Diop.
Thank you, Dr. Meadows, for that wonderful introduction. I want to say that the worst thing that happens to me at conferences is to have to speak after Dr. de Klerk. He's stolen all my lines, you can see when I talk. But the worst part is he's a white man against a black woman. What type of equity is that when we're talking about it? That's not fair. When it comes to talking about the intersection of public health and clinical practice, there is a lot to be said. And of course, I'm not going to have time in 10 minutes to do that. But I'd like to give a very brief but high-level overview of three things. One is perinatal regionalization, which Dr. de Klerk alluded to a little bit. The other one is maternal mortality review in the US. And then the third one is guidelines and circular letters that come out of the Department of Public Health. Because it's been saying that we have to do the work, you guys are doing your job. So with that, I'm going to start with perinatal regionalization. In Massachusetts, in 1985, we developed and implemented regulations for perinatal services to ensure that appropriate but also safe care is provided at appropriate locations. And since then, these guidelines have been updated twice, once in 2006 and more recently in 2017. The challenge with these guidelines is that they are primarily related to the care of the newborn, which he also mentioned. We care more about babies than we care for mothers. So currently in Massachusetts, there is no system that designates levels of care for pregnant women. At the national level, given in response to the increases in maternal morbidity and mortality in the past decades, ACOG and SMFM have developed and published maternal levels of guidelines in 2015. And these guidelines are designated to promote collaboration between maternal facilities and healthcare providers, with the goal that pregnant women will receive care at facilities that are appropriate for their risk. To support implementation of the guideline, the CDC developed the levels of care assessment tool known as LOCATE to allow states and jurisdictions in assessing not only maternal levels of care, but also neonatal levels of care in alignment with the national recommendations and guidelines from ACOG, SMFM, and the AAP, the American Academy of Pediatrics. The proposed levels of care includes 4. One is basic care for level 1s, and then the second one is level 2, which would include level 1 and specialty services, and then level 3, which will include level 1s and 2, plus subspecialty services, and then the highest level, which is the regional perinatal health care centers, which would include all other levels, but provide the highest level of specialized services. The goal being that when pregnant women at risk are seen, they are seen at facilities that are readily prepared to respond to the levels of specialized care, the needed level of specialized care, and by the same token, reducing maternal mortality and morbidity. Now, I want to talk a little bit about maternal mortality reviews. In Massachusetts, maternal death review is authorized under Mass General Law, Chapter 1111, Section 24A and B, and the goal is really to identify and review all pregnancy-associated death from any cause during pregnancy or up to 1 year following the end of pregnancy. And you heard the definitions of pregnancy-associated mortality from Ginger Clark. We're not going to go into that. But essentially, the goal is to gain insight into the factors that contribute to both maternal morbidity and mortality, and to inform strategies to reduce the incidence of these tragic events. And a lot of us in the room here are members of the Maternal Mortality Review Committee. In Massachusetts, we review all deaths. But before that, between 1941 and 1985, the Maternal Welfare Committee at the Mass Medical Society reviewed maternal death voluntarily reported by hospitals. The Department of Public Health sanctioned the process, but we were not involved. And in the late 80s, this process kind of waned for 2 reasons. One was medical liability concerns, and then the other one was perception that maternal mortality was no longer an issue. And Jean showed that in the data. At some point, we weren't even collecting the data anymore. So in the 1990s, the mass hospital regulations were adopted, and hospitals were now required to report maternal deaths within 45 days to the Department of Public Health. But only a few hospitals were in compliance. They were not reporting to us. And in 1997, there was a very high-profile death in a wealthy suburb in Newton, which was highly publicized by the media. And of course, anything that gets the media attention then gets the legislative attention and then everybody's attention. So at that point, the Maternal Mortality Review Committee was established by the Massachusetts Department of Public Health. And now hospitals were not only required to report to the Department of Public Health, but the Department of Public Health was chairing the committee, and we review, like I said, all pregnancy-associated deaths, make recommendations and strategies that we disseminate back to the providers. I thought I was going to impress you with this slide to tell you that case identification was difficult, but I think Ginger Clark did a good job at telling you how complicated it is. Of course, we don't know all the pregnancy-related deaths. We don't know about all the pregnancy-associated deaths because, A, we don't know when a woman dies, we don't necessarily know if she's pregnant because our reporting system right now allows us to know if there was a fetal death event. In case of a fetal demise, at 20 weeks or greater, we know that. But anything that happens below 20 weeks is not reportable to the vital statistic. So we are missing a great deal of pregnancies, losses, and women who died while they had when they were pregnant at less than 20 weeks. But in order for us to pick up on that, we do some data linkages, and we conduct data linkages with our pregnancy to early life longitudinal data system to pick up on some of the data. And the added pregnancy checkbox, which Dr. DeClercq also mentioned in 2014, is also helping us identify some of these cases. Back in the days when we talked to the medical examiner about adding pregnancy tests to when women die, we were told that it was violating confidentiality, so we didn't do it. But with the new revision in 2014, the checkbox allows us to pick up on some, not all. We're still missing a great deal. Now, instead of just looking at pregnancy-related deaths, like Jean said, in Massachusetts, actually, it's a rare event. We've decided as a committee to collectively look at pregnancy-associated, severe maternal morbidity, which are near-miss events, conditions for which women could have died but didn't. And our data indicated that starting in 1998, there is a really sharp increase in severe maternal morbidity. Regardless of how we calculate it, there are a number of definitions related to, including transfusion, excluding transfusion. The rates are going up. If women are not dying, they're sicker. They're getting sicker and sicker, and we see that in the data. As a result, and of course, when you look at it by race ethnicity, no surprise, big gap between black and white. And in fact, in the latter years, the gaps between black and white are increasing. And these are some of the recommendations we made at the Department of Public Health. Each maternity hospital should have clinical guidelines and protocols for the recognition and the management of maternal hemorrhage, including standard timing and criteria for implementation of massive transfusion protocols. The guidelines and the protocol should include procedures that effectively address the clinical risk and management of peripheral maternal hemorrhage. And then, as part of a quality improvement collaborative, we launched a QI project focusing on maternal hemorrhage with 28 hospitals and then maternal hypertension with 10 hospitals. We provided quality improvement training to 18 hospitals to be able to make some progress related to severe maternal morbidity. And then here's the slide Dr. de Klerk showed. We've been monitoring pregnancy-associated death related to substance misuse. Again, alarming trends going just between 2005 and 2014 from 8% to 41%. The recommendations for these coming out of the department were to screen all pregnant women through interviews using a standard tool, at the beginning of pregnancy, at 28 weeks, and at the time she presents for delivery, and then developing training on mental health, maternal mental health for providers to demonstrate proficiency in screening and referring women, and a lot of work with the Mass Perinatal Quality Collaborative around toolkits and best practices. We've been also monitoring oral health. As you can see, we haven't made a lot of progress here, but the recommendations included adding oral health questions to our perinatal care recommendations in collaboration with Mass Health. And we published an oral health guidance for pregnancy in 2016. We are still working with providers around implementation, which has been very challenging. And we do issue circular letters when there are emerging trends. The last one we had was related to substance-exposed newborn. We had several before that related to HIV or H1N1. That's part of what the department does. We share the data, and then we come up with recommendations. And that's my last slide. This is the contact info for DP. Thank you.
Thank you, Dr. Diop. Next, among our panel of experts, I'd like to introduce you to Dr. Rose Molina. Dr. Molina is Assistant Professor of Obstetrics, Gynecology, and Reproductive Biology at Harvard Medical School and is a practicing OB at Beth Israel Deaconess Medical Center as well, primarily in the Dimock Center in Roxbury. Dr. Molina completed her Global Women's Health Fellowship at Brigham Women's Hospital and obtained her MPH here at the Harvard Chan School of Public Health as well. I have the pleasure of having worked with Dr. Molina as a resident when she trained at Brigham Women's, and she was a powerhouse and a dynamic person there with a beautiful heart who's definitely zoned in on this need to focus in on what we can do as clinicians to improve care for women. And so she's going to give you a clinician's perspective about how we can begin to address bias and the impact of bias on the care delivery. I do want to add that I'm introducing these personal anecdotes because it's important to know that this is really sobering statistics about the health of women and potentially our infants, especially for Black women. And it's nice to know that the people that are doing this work, that we're working closely together, that are colleagues and friends, also have really nice human sides about them that we enjoy. And so I'd like to say that Dr. Molina is an avid traveler and a foodie whose favorite destination is Italy because of the food. And so I'd like to bring up Dr. Molina to talk a little bit more about some interventions that she believes would be really impactful for us to address impact of bias with clinicians in the healthcare system.
Thanks so much, Dr. Meadows. I'm so excited to speak to you all today about some potential solutions, at least from a clinician's perspective. I have no disclosures. However, I do want to start with a few caveats. The following solutions that I'm going to discuss are not easy. They require heart and mind, time and effort, resources, commitment, and grit. Even though our panels today focus on system and community solutions, we need to acknowledge that racism exists at multiple levels: personal, interpersonal, institutional, and structural. And we need to define solutions to dismantle racism in all of these spaces. But my brief focus today will be on the clinical encounter and looking particularly around patients, providers, and their interactions. I also want to say up front that overall we have very limited data about effectiveness of solutions specific to maternal health inequities, which are differences that are systemic, avoidable, and unjust. As we talked about earlier today, there's a larger body of evidence around birth outcomes, but less specifically about maternal health, which likely signifies the structural deprioritization of women's health specifically. But the solutions that I present today are likely applicable to inequities across many medical fields. So I just want to start briefly with the story of how I came to this work. I grew up in San Diego on the busiest point of entry between two nations, in an interracial immigrant family, and my parents instilled in me from a very young age the value of learning other languages to connect with people, whether it's family, friends, or strangers. From a young age, I felt compelled to strive for equity in the global South when I realized the stark differences in the opportunities people are afforded just because they happen to be born 15 miles south of where I was born, a circumstance that we all have absolutely no control over. This led me to work with Partners in Health when I was a medical student here at Harvard Medical School, and it was my experience in supporting midwives in rural Chiapas that taught me what it really means to believe that all people are worthy of high-quality health care, no matter where they live, simply because their lives matter. So solution one is to apply a lens of health equity to daily clinical encounters. We need to see our patients, hear them, and validate their lived experiences. Our purpose as physicians is to create a safe space in our clinics to build trust with our patients by connecting with them through our shared humanity, while also recognizing the intersectionality of their own identities. We need to prioritize our communication with them, particularly in shared decision-making, and this means we must listen to understand and not always to respond. Recently, I met a 41-year-old in my clinic who had a recent miscarriage and wanted to talk to me about birth control options. In our short visit, she described how she feels othered in nearly every moment of every day as a recent immigrant who doesn't speak English. She said to me, "Doctora, no soy bruta," which means, "Doctor, I'm not dumb." She went on to describe how she feels the sting of discrimination every day in being treated as if she were dumb just because she does not speak English. She went on about how she pours out her time trying to navigate through life, and even just to find a doctor like myself who can speak to her in her own language. The solution lies in being humble, compassionate, and inquisitive about our patients who come from all walks of life. And I encourage that all of us ask our patients about their lives and just think for a moment what it may be like in their shoes. I'm proud to work at Dimock, a federally qualified community health center in Roxbury, where I'm able to screen for patients' daily needs and link them to appropriate resources, such as health leads. I'm also able to connect patients to the medical care that they need with wraparound services, such as warm handoffs to behavioral health providers or a referral to our detox unit on campus for someone who needs it. For our postpartum patients, one of the most important things I can do is to effectively transition their care to a primary care provider in the same building, especially those with elevated risk of cardiovascular disease and diabetes because of pregnancy complications. This is particularly important, as we saw earlier in the keynote, that cardiovascular disease is now a leading cause of pregnancy-related death, especially cardiomyopathy among Black women. At Dimock, we embrace new models of care that center women of color, such as group antenatal care that allows women to build social support as they experience pregnancy together. And most importantly, we must incorporate equity as a process and not just a process in our daily encounters and not just an outcome. Solution 2 is to recognize implicit bias and build accountability to mitigate it. With regard to maternal mortality, we have seen differences in preventable pregnancy-related deaths by race, which have also been paired with the poignant stories in the media, which call into question the role of bias. We need to recognize how implicit bias saturates all of our lived experiences and daily interactions. Yes, skin color is certainly an important one, as is obesity, appearance, age, gender, among others listed here. The good news is that research shows that doctors are no more biased than other human beings. The bad news is that doctors occupy a place of power and their biases can have important impacts on their patients' health. But the good news is that implicit bias is a habit that can be broken. We have to recognize that this is a lifelong journey for all of us. The goal is not necessarily to stamp out bias, but to be sensitive to it, name it, and hold each other accountable for mitigating it. This requires daily self-awareness, self-reflection, and transformation, and we need to role model this behavior for each other and for our students. It requires humility and a commitment to do better every day. In response to the outpouring of public stories of women of color who felt that their health care team did not listen to their concerns, this past weekend, ACOG, the American College of Obstetricians and Gynecologists, announced its public awareness campaign. I'm wearing the pin here. It says, "I'm listening, every mom, every time." Additionally, there are several bills at the state and federal levels about mandatory implicit bias trainings to address inequities in maternal morbidity and mortality, but they need to be more than a checkbox. We need to identify best practices and content for these trainings so that they actually have an impact on behavior change and patient outcomes. And then we need to identify how to scale those up. Solution 3 is to ensure diversity in the healthcare workforce. We need to build and support a diverse workforce that reflects the patients we serve. A recent study found that Black men seen by Black doctors received more effective preventative care than those seen by non-Black doctors. And this effect seemed to be driven by better communication and more trust. The medical field is making strides in closing the gender gap, with 39% of full-time faculty being female, but only 4% of full-time faculty are females of color. In 2015, only 6% of all medical graduates were Black and 5% were Hispanic, yet 13% of the U.S. population identifies as Black and 18% as Latinx or Hispanic. The need for a diverse workforce extends beyond just medical schools, but also to other health professional schools such as nursing, and the pipeline needs to begin as early as middle school. Secondly, we need to center and support patients through interdisciplinary and culturally congruent care teams. As the result of the many stories of mistreatment during childbirth among women of color, as we mentioned, Serena Williams, and then the Lost Mother series, some women now are actually scared to deliver in hospitals and are seeking alternative birth options. This can, at some times, lead to strained relationships among the healthcare team, between lay midwives, professional midwives, doulas, obstetricians, and other healthcare providers. We need to change the narrative that sometimes depicts maternal health professionals as blaming each other for bad outcomes, and we need to move forward together as a truly integrated team, as shown here with the patient at the center and surrounded by a team of providers with different levels of expertise. To that end, we need to recognize a just culture that essentially no one comes to work trying to harm people. And we also need to see that just like our patients, healthcare providers also function in a structural context that may constrain their behaviors. We are seeing an epidemic of physician burnout, as published by many of our colleagues right here at Harvard. Nearly 45% to half of OBGYNs nationally report symptoms consistent with burnout, and this is also true among midwives. We know that burnout is associated with major medical errors. This is not an excuse. It simply means that we need to find a system solution for the physician work environment in parallel. We in the United States can learn a lot from other countries regarding the positive impact of culturally congruent doulas and community health workers. Until our workforce reflects the patients we serve, we need patient advocates like them who can come from the same communities and help our patients navigate transitions between home and hospital and back home. Solution number 4 is to foster inclusion and belonging in the healthcare workforce. We need to build an inclusive environment to support and retain people of color in our workforce, and that may mean developing programs such as mentorship, coaching, and sponsorship that really allow the healthcare workforce to feel valued and supported in their work. John A. Powell is a professor of law and African American studies at UC Berkeley, and he argues that we need to go beyond inclusion to belonging, a radical idea that is much more than being seen and being included. He writes that belonging is not just how we treat each other, but it is how we actually organize our economy, our structures, our schools, our faiths, so that everyone belongs, and recognizing we still have differences. Lastly, solution 5 is to integrate health equity and advocacy training in undergraduate and graduate medical education. We need to teach that structural competency to understand the underlying power structures that shape the social determinants of health that we all know about. Structural competency has been defined as the trained ability to discern how a host of issues defined clinically as symptoms, attitudes, or diseases also represent the downstream implications of a number of upstream decisions about such matters as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definitions of illness and health. This graphic comes from the Boston Public Health Commission, which illustrates how racism is the driver of the variation in social determinants of health, which we all know impact health outcomes. We need to ensure diversity of clinical cases that do not perpetuate stereotypes, and we need to stop racializing illness and disease when we teach our medical students. We need to teach the history of racism in medicine to medical students and residents and acknowledge our profession's mistakes so that we can better understand the distrust patients have in our profession. For example, in my own profession as an OBGYN, I had not heard the story of Marion Sims until I wasn't attending. He is considered one of the fathers of gynecology, and his name is commemorated on a retractor that gynecologists use on a daily basis. It was not until after I became an attending that I learned that he practiced surgical techniques to treat obstetric fistula on slaves without their consent and without anesthesia. This is his statue in New York City that was only taken down 1 year ago in April 2018, and the other statues commemorating him still exist. We need to teach our students about the history of redlining in Boston and the decades of the Federal Housing Authority's disinvestment and explicit racist policies that impact where people live and their health and well-being to this day. We need to tell the story of Henrietta Lacks, whose cervical cancer cells were taken from her without her consent and used to develop the most commonly used human cell line called HeLa cells. We also need to acknowledge that there were forced sterilization campaigns that occurred in the 1970s among the Mexican immigrant community. We should also teach about the history of social movements and contemporary frameworks that are relevant to the practice of medicine, such as obstetric violence, which originated in the human rights movement in Latin America, the White Ribbon Alliance, and reproductive justice. Lastly, we need to infuse advocacy training into medical schools and residencies by telling our patients' stories in the places of power and using our platform and status in society to speak out for what matters to our patients, such as expanding Medicaid and paid parental leave. Thanks.
Thank you, Dr. Molina. I'd like to introduce our third speaker, who is a colleague as well, also another practicing OBGYN, Dr. Jackie Grant. Dr. Grant is a practicing maternal fetal medicine doctor and the director of the Regional Perinatal Care Center in Columbus, Georgia. She also received her medical degree from Emory University, her residency at Emory University, and her maternal fetal medicine practice training was at UNC Chapel Hill. And she had completed her MPH prior to coming to our fellowship, but then also completed an MPA here at Harvard University. Something she and I share in common is that this interest and love for the idea of group prenatal care, and so something that Dr. Grant worked on across the state of Georgia was implementation of centering pregnancy programs across the state and received an award for such. Importantly, her humanism in medicine is obvious in the fact that she's invited here as a panelist and the work she's done, but also her humanism extends to really interesting pieces of art and her skill for antiquing. And so you can definitely have a conversation with her about that, of a beautiful brooch that she brought with her today. But with no further ado, I'd like to bring up Dr. Grant.
Thank you, Audra, for that kind introduction. I am one of 2 MFMs and the director of the Regional Perinatal Center in Columbus, Georgia. And for those of you who aren't familiar with Columbus, Columbus is about an hour and a half south of Atlanta. The demographics are about 50-50 black, white, about 6% Hispanic, and about 2% Asian. We actually boast some of the worst perinatal outcomes in the state, and that was one of the reasons why I chose to go there. In fact, in the last 2.5 weeks, I have had personal experience with 2 maternal deaths. Let me just say that we are, being in Georgia and in South Georgia, we are located in the belt buckle of the stroke belt. It is very, very uncommon for us to see hypertensive emergencies. I can't tell you how many times just from my office I've actually sent patients, which my office is right across the street from the hospital, via ambulance because of blood pressures 215 over 115. It is so common to see just extremely high blood pressures that I think our physicians and our nurses on the hospital side are just desensitized. So I would be rounding, doing antepartum rounds, and just be stunned the next day by these just ridiculous blood pressures that went untreated during the night. And it just became so concerning to me that I took it to the executive OBGYN committee, which I am a member of, and I said, we need to do something about, this failure to treat. It's the standard of care to treat blood pressures of 160 over 110 or greater, and we're not following that standard. And what is going on? And so to my surprise, I thought, because I was like, we need to be actually, and how do I advance this slide with this one? So that was our hospital. So I said, we need to be practicing in line with the Council on Patient Safety and Women's Health Care hypertension bundle, which is, is evidence-based and endorsed by ACOG of treating these blood pressures that are consistently or persistently elevated 160 systolics over 110 diastolics. And why aren't we doing that? And to my surprise, I actually got pushback. And the pushback actually mostly came from nurses, the nursing directors and the nursing. And the concern was that, well, if our nurses, I was like, part of this hypertension bundle is notifying a mandate to notify the physicians. And we aren't even consistently doing that part. The other part of that response is to treat within 30 to 60 minutes. So surely we're not doing that either if we're not, consistently notifying. So some of the nurses on the committee said that, well, our nurses are not going to call these physicians at night because they're afraid. And they're afraid they're going to get yelled at, and they're afraid of this, and the doctors aren't going to treat anyway because these blood pressures are commonly seen, and so they're not going to, the doctors aren't, going to treat, and we don't really want our nurses being yelled at by the doctors in the middle of the night. And I was just floored by this. I mean, I think my head was about to explode, and I'm a very sort of passionate person, and my voice started to get high-pitched, and I was like, well, all it's going to take, I said, this is a quality and safety issue, and this committee is charged with that, and all it's going to take is one 15-year-old that strokes out, and we won't have a leg to stand on as a hospital. So at that point, I think I got their attention, and so there was some agreement around the fact that it was, in fact, a quality and safety issue, and that we needed to promptly address the issue. So we basically sent out a letter to all of the practicing physicians, and we posted the letter on labor and delivery, and we attached that to the recent ACOG committee opinion that came out in February about treating acute hypertension. And I think we have really gotten some good response. I'm no longer seeing, this issue as much as I was on antepartum rounds. And in fact, most recently in our executive committee, the nurses were actually bragging about one of the nurses that had to check one of the residents who had an outburst when the nurse called and said, don't call me about that blood pressure. I only want you to call me if the blood pressure is greater than 180, a systolic of 180. And I might add that the hospital has standing orders and have had those standing orders for quite some time, but a lot of the doctors had personalized their standing orders and had changed their standing orders to tell the nurses not to call them unless the blood pressure was over 180 systolic. So anyway, the nurse basically, put the resident in check, and the blood pressure was promptly treated. So, I say all of this about these, for most doctors really want to do the right thing and the best thing for their patients. And just by, giving them the guidance and putting it out there, the majority of people are going to fall in line with that. But there are always going to be some that's not, and for that reason, you do need a system-wide approach. And from my experience working in public health and now working in a hospital system, is that you have to identify a problem. You have to make that problem be understood as to why that's a problem and what the solutions are. And then you have to empower the people. The leadership has to do that part, that front end part. And then you have to empower the people, and in this case, it was the nurses, really, to speak up and to report. And then you have to have a committee that responds to it and monitors it and gives feedback about it. So I think that's just one example of what we've done at Piedmont Columbus Regional from a systems perspective. The other thing we've done is that a lot of our patients that are candidates for low-dose aspirin therapy, so one of these upstream solutions, low-dose aspirin therapy has been shown to decrease preeclampsia. And while it only decreases preeclampsia about 10 to 30% is all we basically have, but it has been shown to decrease the risk of severe preeclampsia or pregnancy-induced hypertension, resulting in preterm births less than 34 weeks of 60%. So what I found in my consultative practice is that a lot of our patients are coming to me well after the time where it would be most effective, and aspirin is most effective before 16 weeks. So we've done an outreach and similar outreach, sending the committee opinion, sending a letter to the physicians, and we are seeing some improvement. We've got a long way to go there. We don't have a systematic approach that we can deal with community physicians on that, but we are seeing some improvement. So again, I just wanted to close by saying that sometimes it does take these overarching system-wide changes to really kind of affect practices. Thank you.
Thank you, Jackie. That's very near and dear to our heart as well. So our state PQC is working similarly to implement guidelines related to the Council on Patient Safety and Women's Healthcare Safe Motherhood Initiative through AIM. So there are bundles of safety bundles called the Alliance for Innovation Maternal Healthcare AIM bundles that our state is working on implementation. So I think that's really appropriate and important to discuss. I want to just quickly encapsulate some of the things we've heard today just with our panel of obstetricians and gynecologists talking about systemic interventions to address this trend that we saw from Dr. DeClerc's slides on maternal mortality and the rising rates and the disparity related to that. And so for those of you with a MPH background, who remembers the social ecological diagram that shows the interrelationship between starting at human, human, out to the greater systems of your community, out to greater systems related to public policy, et cetera. And so with that said, it's important for us to think about where these interventions lie and the interrelationship between them. And so importantly, we're hearing about what we can talk about with our patients and how clinical providers can be selected, for lack of a better word, to engage with a provider that would be someone they could relate to through language, through an experience of feeling like they belong in their healthcare system. We've also heard a little bit about how around that, within our hospital systems, there are evidence-based safety bundles that we can start to put in place to start this interplay of conversations and communication around patient care and standardizing and bringing quality to the way that we offer that care. And then greater than that, we also have these state policies and state activities that happen, like our maternal mortality review committees, the work on this maternal levels of care, so designating hospital designations. And then greater than that, we've got these areas related to public policy. And so you'd heard in Dr. DeClerc's slides the policy that was passed related to funding maternal mortality review committees. But as you can see, there's 1 to 4 examples maybe in each of those areas, potentially 5. And with that, there's more to go and more activity for us to grow within. And so with that, I'd like to allow folks to stand up and bring some questions to our panelists, because this is an interesting area of multidisciplinary teaming that we can start to engage in across disciplines, across areas within public health, and across our diversity of thought, so that we can really start to tackle this problem. Because I don't see anyone standing up just yet, and we have some more time, I'd like to take the liberty to ask the first question. I think that what's really interesting here to hear about is something that Dr. Molina brought up, and I think interesting for our panel, so the 4 of us are all OBGYNs, and that is this, who is having the conversations. A lot of what's been in the media has actually focused in on other professionals related to obstetrics care, and those would be our doulas and our midwives, more so than our obstetricians. And I'd actually like to add that there seems to have been a little bit of a tension created between the 2 groups of practice in terms of having this conversation and how we can work together. One of them from a recent conversation that was hosted at another university system during Maternal Mortality and Maternal Health Week came up when the person asked the question about why would somebody who had a maternal hemorrhage deliver again in a hospital? Why wouldn't you go to a birth center? Sort of creating this assumption that delivering in a hospital leads to these negative outcomes, and delivering in a birth center would lead to positive outcomes. I want to throw that toward you guys and hear your thoughts on care delivery and the types of facilities that women are allowed to have babies, and what you think about the how that plays into that conversation between the groups of people that deliver obstetrical and prenatal care to women when they're pregnant.
I'm happy to maybe say a few comments about that. I think I certainly feel that tension a little bit, at least how some of the stories are being portrayed in the media, that there's this dichotomy or between hospitals and other options, whether it's community places, birth centers. And I think the important thing is a lot of the work around regionalization and maternal levels of care. So ACOG is doing a lot of work around defining what sort of risk stratification categories are appropriate for different levels of care. So an independent birth center being like a level 1 level of care up to like a tertiary or quaternary level of care. So I think it really needs to be individualized based on the woman's preferences and then what her potential risks for having a complication during childbirth really are. But I think it goes back to that relationship between whether it's a midwife and a patient or a obstetrician or a nurse practitioner. I think what really matters is that there's trust in that relationship and that these can be open conversations about what a woman's potential risks are, knowing that in obstetrics there's so much uncertainty and we cannot guarantee any particular outcome for any particular person. And so I think that we need to move sort of narrative over into thinking about how can we engage patients in these conversations and talk about these risks that we are uncertain about, and how to help them sort of navigate that decision making about where is most appropriate for them to give birth.
I've had the privilege to work with some excellent mid-levels and nurse practitioners, certified nurse midwives, and I admire a lot of the work that they do. I myself have just taken care of so many high-risk patients even before I became an MFM, so that's always been an issue that I struggle with, especially with home births. While that's a good alternative for some women, I don't know, not many of the women that I serve that would be a good alternative for. So I think we have to be very careful in the selection of people that's doing home births again. And I think most midwives do really screen their patients very well and work with obstetricians to make sure that's happening. So, but again, a lot of the people, just the people that I work with, certainly aren't, good candidates for that. And that's why I'm in the specialty that I'm in.
I want to add that, as shown, most of the pregnancy-related deaths are preventable, and pregnancy itself should be a wonderful and beautiful event and experience, and it shouldn't be ending in a tragic manner. And most of the time, the hypertensive crises we see are related to extremely elevated stress levels, which could be sort of managed with someone who may not be a clinician, but if helping decrease that stress level is brought up in the hospital setting, in addition to the medication we give, I think that's the key, because standard of care alone will not do it. We know that clinicians do deviate from standard of care, and sometimes that is what leads to tragic events. That is what leads to all the complications we see. Women should be treated based on their needs, not just with standard of care. It is in addition to standard of care. And what we've learned that is doulas and nurse midwives tend to give the patient more attention than they would ever get in a hospital setting. That alone can completely drop your blood pressure, put you in a comfortable mindset that could improve your outcome. And I think it should be a combination of the two. So we should really sort of bring that relationship. In most countries, deliveries are done by midwives, not obstetricians. This is the only country where the majority is done by the obstetricians. And we do see that, in other countries, they do tend to have better outcomes based on, again, really the care you provide, that compassion, how the woman is, viewed as important and listened to. Like Ginger Clark said, we really don't do a good job at listening to our patients. A lot of women who died, it was not because the care wasn't there. It was there, but they're just not being listened to.
And that's what I loved about the centering model. I love about the centering model. I was in public health for 10 years prior to going back and doing a fellowship, and we actually administered in my health district the first public health administered centering program in the state of Georgia. And I wish that even for providers that didn't have centering care, the one thing that I loved about it was that you spend more time with patients. You got to know them more. You really knew them personally after doing 2-hour sessions for each visit. But part of the experience that we had in public health with our centering program was we had a multi-specialty team of facilitators. We had a social worker in there during our sessions. We had nurse practitioners, and we didn't have midwives, but we had nurse practitioners that provided most of the care, and sometimes I was in the sessions too. And then we had other providers that came at different times into the session. I believe that a lot of the care in this country, prenatal care and care beyond the prenatal care and even postpartum extension, would be so much better if our patients were if that care was delivered by multi-specialty teams. Because different people are going to see different things and address different needs that a provider, a busy provider, will not address. And so I mentioned about the maternal deaths that we had just in the last 2 weeks. Well, one of those deaths was in a patient that I consulted on the hospital, and I think she had no prenatal care, came in with premature rupture membranes, delivered. She was homeless, but while she was homeless, she was under an alias because of some domestic violence issues. She had a C-section, was discharged, and within 2 to 3 weeks of her discharge, she was murdered in a park. Now, that was a system that we provided excellent medical care, but that was a systems issue that was not addressed prior to her delivery and going back out there in a situation she came from and we were protecting her from in the hospital. So again, I think it's crucial, and I think that not only doctors, but all levels of providers, social workers, if we could provide that kind of care, then we would have much better perinatal outcomes here in the United States.
Thank you for that. I agree with that. Do we have time for additional question? We have one standing and one live chat question. So we'll keep our responses brief to this. The question reads, so much of what is prioritized in Massachusetts healthcare policy is focused on value-based care, return on investment, and demonstration of cost containment. How can providers lead the culture shift in systemic values? Admittedly, that's a tough question. It is, from the state perspective, Fifi, I don't know if you'd have comments.
I can speak from a local, back in my public health issue. I mean, we identified the need in South Georgia where we had contiguous counties with no prenatal providers. We didn't have prenatal providers in public health, but I trained actually 2 nurse practitioners on how to do prenatal care. We started our centering program, and we were able to get grant dollars. There was no money from the state, and we actually went to different funders and went to community obstetricians because we don't do deliveries. We had to have their partnership. And so we've got to, I don't know if this is answering that question, but I think it is that we've got to show people where the stakes are and how that everybody can be a part of the solution. And we partner with a lot of non-traditional providers to bring centering pregnancy to South Georgia.
Mm-hmm. Thank you.
Yes, hello. Thank you for a great panel. I'm Dr. Maureen Paul. I'm the Director of Family Planning at Beth Israel Deaconess Medical Center. And in the interest of talking about interdisciplinary teams, I just wanted to urge us to include family planning as part of our teams. I recently attended a conference in Las Vegas that was sponsored by the new president of the Society of Maternal Fetal Medicine along with ACOG, and for the first time the Society of Family Planning was part of that, and it had to do with reducing morbidity and mortality just in women with high-risk medical conditions. And we know that pregnancy intention as well as interpregnancy intervals, affect birth outcomes as well as infant outcomes, and that it's important to think in the preconception period, and have pregnancy planning as well as at the time of discharge, right? Have pregnancy for your next pregnancy. Have pregnancy planning be an important element, as well as pregnancy termination being an option for women with high-risk medical conditions, which often is not offered, or the method of choice may not be offered because family planning people are not included in the conversation. So I just wanted to bring that into our conversation, and the question is, how much is kind of this preconception and kind of planning perspective being talked about in the conversation that's happening across the state around maternal, reducing maternal mortality?
Not enough.
Dr. Molina?
I would say there's been a renewed interest in it, particularly from ACOG around postpartum care and optimizing postpartum care and thinking about it as a continuum and not just a single visit at 6 weeks. And certainly, like, comprehensive family planning, counseling actually belongs in prenatal care to optimize the choices for postpartum, and then to, as you just mentioned, get to an ideal birth spacing sort of plan for all of the positive impacts of that. I think that there is also, interestingly, I think it's at APHA, the sections around maternal health and then sexual and reproductive health were separate. But from what I understand, the president-elect, who I believe is Monica McLemore from UCSF, is deliberately and intentionally integrating those two, because it's kind of a false dichotomy that they shouldn't be in separate camps, that they really need to be considered holistically and sort of on the continuum, given that there's preconception, there's interconception, as many people in this country have more than one pregnancy. And so I think there is a growing interest in melding, or bringing those two fields together.
Something I'd also like to add for our state, for Massachusetts, is our State Perinatal Quality Collaborative. As we're doing work implementing these safety bundles for AIM, we're starting with opioid and looking at this maternal mortality issue and the rates there. We are also actively engaged in the State of Massachusetts PIC program, which is the Partners in Contraceptive Choice and Knowledge. That's being led by Kate White through BMC. And through that program that's state funded, the focus is not just simply about contraceptives or the contraceptive methods and training physicians on how, or their providers on how to place, long-acting reversible contraceptives immediately after delivery and those kinds of issues. It's really more about how do we engage in communities and populations of women so that they understand what their contraceptive choices are and raise the knowledge in a way that is culturally humble as we have those conversations. And so something that we are thinking about on the state level and actively engaged in as well. With that said, I think I'm going to start getting an eyebrow raise from Dr. Kaplan if I don't wrap our session up, so she comes to moderate her next group. I want to offer a profuse thank you to the panel that's here. Again, a collection of people who are not only experts in their areas and leading the charge, but also dear colleagues and friends. And so thank you again. I'd like to give them a round of applause.